Welcome to this audiobook entitled Hepatitis C virus infection. As a way of introduction, we will first discuss the epidemiology of hepatitis C virus, abbreviated as HCV. Chronic hepatitis C virus, abbreviated as HCV, infections pose a substantial public health burden globally and in the United States, where HCV is the leading cause of liver transplantation, according to Kim 2017. Transmission of HCV occurs primarily through exposure with contaminated blood, and the most common risk factors for infection include injection drug use, blood transfusions from unscreened donors, unsafe therapeutic injections, and other healthcare-related procedures, according to the CDC 2017. Progression of liver disease caused by chronic HCV is often insidious and unrecognized, contributing to substantial morbidity and mortality. Complications from chronic HCV infection disproportionately affect patients born in 1945 to 1965 and members of minority racial or ethnic groups, including Hispanics, African Americans, and Asians, according to Vution 2016. In 2007, HCV-related deaths surpassed those attributable to HIV infection, according to LI 2012. Morbidity from chronic HCV infections is often accelerated with concomitant HIV or hepatitis B virus, abbreviated as HBV, infection, obesity, older age at acquisition of HCV infection, male sex, alcohol consumption, and daily marijuana use, according to Hezode 2008, and Shepard 2005. Next we will discuss HCV genotypes and subtypes. There are 7 major HCV genotypes, abbreviated as GTs, GT1 to 7, with 67 subtypes, e.g., A, B, according to Smith 2014. Treatment recommendations are available for genotypes 1 to 6. Although the prevalence of particular genotypes and subtypes can vary by geographic region, genotype 1 is the most common in the United States and worldwide. In the United States, genotype 1A is more prevalent than genotype 1B, followed by genotypes 2 and 3, according to Smith 2014. Successful cure of HCV is defined as a sustained virologic response, abbreviated as SVR, currently established by an undetectable HCV RNA, at least 12 weeks after completing treatment. Historically, genotype 1 was the most difficult to treat infection, with SVR occurring in 20% to 50% of patients treated with pegylated interferon and ribavirin, which was lower than the SVR rates in patients with genotype 2 or 3, according to Manns 2001. More recently, clinical studies identified a reduced SVR in genotype 3 infections, particularly among patients with underlying cirrhosis. Moreover, infection with genotype 3 can accelerate progression to cirrhosis and development of hepatocellular carcinoma, according to McMahon 2017. Currently, infection by a particular genotype is important because this can affect decisions to use specific therapies. Newer, pan-genotypic therapies have simplified HCV therapy and equalized SVR rates for all genotypes. Next we will discuss the evolution of treatment. Since 2001, the treatment of HCV has been based on pegylated interferon and ribavirin for treatments lasting 24 to 48 weeks. The first direct-acting antivirals, abbreviated as DAAs, Boceprevir and Tenofovir, were approved for use in combination with interferon and ribavirin in 2011. They improved SVR rates but often included more severe adverse effects and profound laboratory abnormalities. In 2013, Cimaprevir and Sofosbuvir were approved. Although their initial approval was for use in combination with pegylated interferon and ribavirin, data showed that the two DAAs could be used in combination, thus offering the first all-oral, non-interferon-based HCV regimen, according to Lavitz 2014. Subsequently, in 2014, approval of ledaspivir and sofosbuvir offered the first single-tablet combination regimen for genotype 1, allowing an all-oral, interferon-free therapy with a markedly reduced treatment duration of 8 to 12 weeks. Other all-oral therapies quickly followed with activity against other HCV genotypes and ability to use in an expanding pool of patients, including those with renal insufficiency and those undergoing hemodialysis. In discussions of drug trials, the term treatment experienced, abbreviated as TE, refers to patients who were previously treated with interferon-based therapy. Patients who were previously treated with an all-oral DAA-based therapy are specifically referred to as such. Next, we will look at clinical guidelines. Recommendations for the treatment of patients with chronic HCV are published online in a joint guideline by the American Association for the Study of Liver Diseases, abbreviated as AASLD, and the Infectious Diseases Society of America. Although the initial guidelines identified specific patient groups that were considered high priority for treatment, e.g., those with advanced liver disease or HIV co-infection, current guidelines recommend treatment for all patients with chronic HCV. The only patient population for whom treatment is not currently recommended is the patient group with a short life expectancy that are unlikely to benefit from HCV therapy, liver transplantation, or other directed therapy. In resource-limited areas, individuals with advanced liver disease, individuals who have undergone liver transplantation, or those at greatest risk of liver disease progression including HIV-HCV or HCV-HBV co-infection may have higher priority for treatment. Similarly, HCV treatment may be prioritized in patients for whom the infection is associated with extrahepatic manifestations such as cryoglobulinemia or evidence of end organ damage such as renal impairment. Next, we will discuss access to HCV therapies. Despite the AASLD's recommendations to treat all patients with chronic HCV, initial access to HCV therapies was at first limited to patients with advanced liver disease in many states. Several lawsuits or threats of lawsuits prompted changes in access to treatment, however, additional barriers to treatment remain. In many states, patients are required to demonstrate proof of abstinence from alcohol or illicit drug use. Access to opioid substitution therapy, counseling, education, and referrals to supportive services such as psychiatry are strategies to overcome these barriers. The AASLD guidelines do not support these restrictions and state that there are no data to support the utility of pre-treatment screening or alcohol use, according to AASLD 2017. Similarly, to effectively address the HCV epidemic, HCV treatment needs to expand to patients with ongoing illicit drug use to prevent new infections. Next, we will discuss pharmacoeconomic considerations. Costs of HCV therapy were the subject of substantial scrutiny at initial approval because of the wholesale acquisition costs, currently ranging from $39,600 for glecaprevir with pibrentasvir to $147,000 for daclatasvir with sofosbuvir for a 12-week treatment, according to Saganoxi 2017, Red Book 2017a, 2017b, and 2017c. The actual cost of therapy is difficult to determine because negotiated discounts are not publicly available. Formularies typically limit available HCV therapies, opting to include either one or two HCV therapies only. Because of the inability to use protease inhibitor, abbreviated as PI-based regimens in patients with Child-Turcotte-Pugh, abbreviated as CTP, Class B or C cirrhosis, many formularies include a preferred agent for non-cirrhotic or CTP Class A cirrhosis and another agent for patients with Child-Turcotte-Pugh Class B or C cirrhosis. In most cases, pharmacotherapy for HCV is strictly defined by formulary preference. Next we will discuss the evaluation of patients with HCV. We will first look at the initial diagnosis of patients with chronic HCV infection. Patients with chronic HCV often have nonspecific symptoms or are asymptomatic. Recommendations for evaluating chronic HCV infection include an initial test for HCV antibody anti-HCV using an FDA-approved test such as laboratory-based or point-of-care assays. A positive anti-HCV test denotes a prior exposure to HCV, resolved infection, a current HCV infection, or a false positive test, figure 2:1. Confirmation of a current HCV infection requires HCV nucleic acid testing for HCV RNA. In severely immunocompromised individuals or those with suspected recent HCV exposure less than 6 months, anti-HCV may be falsely negative. In these patients, it is reasonable to test for HCV RNA to clarify the patient's HCV infection status. A reflexive test for HCV RNA, when the HCV antibody is positive, is available in some laboratories. Patients who completed HCV treatment are evaluated for SVR by repeating the HCV RNA at least 12 weeks after completing treatment. Of importance, anti-HCV remains positive even after successful cure and does not confer immunity for reinfection, nor does it indicate ongoing HCV infection. If reinfection is a concern, HCV RNA should be repeated, according to AASLD 2017. Next we will discuss the initial evaluation of liver function. Patients with HCV should be staged for the level of underlying liver disease to guide initial and follow-up treatment. Initial evaluation includes an assessment of liver function, e.g., albumin and INR, and inflammation, e.g., ALT and AST. A CBC with platelets can identify anemia as evidenced by reduced hemoglobin concentrations, which can affect the decision to use ribavirin. Furthermore, thrombocytopenia, a common finding in chronic liver disease, is a marker of advanced fibrosis and portal hypertension, according to Afdal 2008. Renal function should be determined because HCV treatment decisions vary depending on the level of renal impairment, with also fosbuvir-based therapies limited to patients with an estimated glomerular filtration rate (eGFR) greater than 30 ml per minute per 1.73 meters squared. Serum creatinine clearance offers insight on the appropriate dosing for ribavirin. Next we will discuss the determination of cirrhosis and staging of cirrhosis. Cirrhosis can be determined using several laboratory and clinical markers. Although liver biopsy is the gold standard for identifying cirrhosis, it is an invasive procedure with the potential for serious complications and poor patient acceptance. Liver biopsy is limited by both sampling error and significant interobserver variability, which can miss the diagnosis of cirrhosis, according to CIF 2010, French METAVIR Cooperative Study Group 1994. Cirrhosis can be identified using non-invasive imaging modalities, e.g., ultrasonography, CT scan, or transient elastography. Minimally invasive tests, i.e., simple blood tests, using indirect biomarkers, e.g., CBC, or liver enzymes, can calculate scores such as the AST platelet ratio index, abbreviated as APRI, or FIB4, which includes AST, ALT, platelets, and the patient's age, to determine the level of fibrosis and likelihood of cirrhosis. Similarly, direct serum fibrosis marker panels that measure components of the extracellular matrix produced by activated hepatic stellate cells can assess whether a patient has cirrhosis. The presence of cirrhosis in patients with chronic HCV infection can affect treatment choice. For HCV treatment decision-making, the CTP scoring system Table 2-1 is used to assess the severity of liver dysfunction in patients with cirrhosis. Patients with cirrhosis are at risk of developing complications including varices and hepatocellular carcinoma, which require routine monitoring. Moreover, the presence of cirrhosis affects HCV treatment decisions and can affect the use of other medications such as limiting acetaminophen exposure to less than 2 grams per day and avoiding all NSAIDs. Furthermore, patients with chronic HCV should complete vaccination for hepatitis A virus and HBV as well as the pneumococcal and influenza vaccine. Pause the video and carefully scrutinize Figure 2-1 summarizing testing algorithm for HCV infection. Pause the video and carefully scrutinize Table 2-1 summarizing CTP scoring for cirrhosis. Next we will discuss monitoring values. We will begin with HBV reactivation. All HCV DAAs include a boxed warning for HBV reactivation, with recommendations to evaluate patients for potential co-infection of HCV and HBV before initiating DAA therapy. The guidance stems from an FDA warning after 24 cases of HBV reactivation were identified in HBV-HCV co-infected patients treated with DAAs, according to the FDA 2016. The reported cases included 2 deaths and 1 liver transplant. As a result, all patients evaluated for HCV DAA therapy should be evaluated for co-infection with HBV surface antigen, abbreviated as HBsAg, HBV core antibody, anti-HBC, and HBV surface antibody, anti-HBs. Patients who have active HBV infection should be evaluated for HBV treatment. Patients with evidence of HBV infection who do not meet the HBV therapy criteria require HBV DNA monitoring every 4 weeks during HCV therapy and immediately after HCV DAA therapy to assess for potential HBV reactivation, according to the AASLD 2017. Less clear is the approach to patients with evidence of inactive HBV for which monitoring of ALT during DAA therapy may suffice as a surrogate for HBV reactivation and flares of hepatic injury. The mechanism for HBV reactivation is not understood. Reactivation of HBV occurs with immunosuppressive therapies such as rituximab or etanercept, however, DAAs have no immunosuppressive effects. Some level of viral interference likely occurs in individuals co-infected with HCV and HBV. Next we will discuss HCV RNA and pretreatment resistance testing. Before initiating HCV treatment, a quantitative HCV RNA should be obtained to document chronic HCV infection. Recommendations for pretreatment resistance testing exist for specific therapies, depending on the genotype. See Table 2-2. If therapy with elbasvir with grazoprevir is considered for patients with an HCV genotype 1A infection, pretreatment resistance-associated substitution, abbreviated as RAS, testing is needed to identify whether specific nonstructural protein 5A (NS5A) RASs are present at baseline, which will necessitate adding ribavirin and extending the treatment to 16 weeks, according to the AASLD 2017. Because of the need to test for the Q80K substitution and the availability of other highly effective agents, Cimaprevir is not a recommended or alternative regimen for patients with compensated cirrhosis and genotype 1A. For the treatment of genotype 3 infections, the package insert for sofosbuvir with velpatasvir and the national treatment guidelines differ. The guidelines recommend pretreatment RAS testing for the Y93 mutation in patients with genotype 3 who have compensated cirrhosis or a TE, according to the AASLD 2017. If the Y93 mutation is found, the guidelines recommend adding ribavirin. This is in contrast to the package insert, which does not recommend RAS testing. The rationale for RAS testing and need for ribavirin stems from the Astral-3 study, according to Foster 2015. According to the guidelines, patients with decompensated cirrhosis do not require RAS testing because the recommended treatment regimen already includes ribavirin, and detection of the Y93 mutation would not alter the treatment course, according to the AASLD 2017. Patients without cirrhosis who are treatment naive also do not require RAS testing because RASs appear not to affect treatment outcomes in this patient population, according to Foster 2015. Similar resistance recommendations exist for daclatosphere plus sofosbuvir. Resistance testing is generally recommended when the results will modify the treatment course, which often includes adding ribavirin and/or extending the treatment duration. Clinical use of resistance testing may vary. Among DAA therapy failures, there is no specific recommendation for resistance testing before using sofosbuvir plus velpatasvir plus voxeloprevir for retreating patients with genotype 1, 2, 3, 4, 5, or 6. Next we will discuss general monitoring values on treatment. The frequency of monitoring on treatment varies depending on clinical need. At a minimum, a CBC, SCR, and eGFR, HCV-RNA, and liver function panel should be obtained at treatment week 4 and repeated as clinically indicated, shown interval 2 to 3. Because of concerns for potential increases in ALT with elbasvir with grazoprevir, hepatic function testing should be repeated at treatment weeks 8 and 12 for patients scheduled for a 16-week treatment. Patients concurrently taking ribavirin will require more frequent CBCs. An HCV-RNA at treatment week 4 is currently recommended, though the clinical usefulness of the test is unclear. Patients who do not have an HCV-RNA at week 4 should not have their HCV treatment interrupted or risk HCV treatment failure. Most patients will have an undetectable HCV-RNA. For patients in whom the HCV-RNA is detected or quantifiable, the HCV-RNA should be rechecked 2 weeks later, at treatment week 6. A detected or quantifiable HCV-RNA is not an indication to discontinue HCV therapy unless the HCV-RNA has increased by more than 10-fold, more than 1 log, from the prior test. Expert opinion varies on how to treat patients with a quantifiable HCV-RNA. Data are limited, and guidelines currently do not support adding ribavirin or extending the treatment duration, according to the AASLD 2017. Pause the video and carefully scrutinize Table 2-2, summarizing the HCV DAAs with pretreatment resistance testing recommendations. Pause the video and carefully scrutinize Table 2-3. Summarizing the suggested monitoring for patients undergoing HCV therapy. Next we will discuss the treatment of HCV. Treatment of HCV uses DAAs. The DAAs act on the HCV virion at one of 3 major targets, as shown in Table 2-4. The DAAs must be used in combination for efficacy and to prevent treatment-emergent RASs. As a group, the DAAs are well tolerated, associated with few laboratory abnormalities, and available for oral dosing. And now, pause the video and carefully scrutinize Table 2-4. Summarizing DAAs by class and common suffix. Pause the video and carefully scrutinize Table 2-5 summarizing the adverse effects of DAAs. And now we will discuss the adverse effects of DAAs. Overall, the DAAs are well tolerated and result in far fewer adverse effects and laboratory abnormalities than pegylated interferon. In clinical trials, the most commonly reported adverse reactions with DAAs are fatigue and headache, as shown in Table 2 to 5, according to Quo 2016, Feld 2015, Zuzem 2015, Afdal 2014a, 2014b, Pordad 2014, and Sulkowski 2014. Patients with cirrhosis had higher rates of adverse reactions, with 31% also reporting asthenia, according to Bourlier 2015. Among patients with chronic kidney disease, including those receiving hemodialysis, nausea was more common with Elbasvir with Grazoprevir use, according to Roth 2015. Similarly, among patients with renal disease treated with Glecoprevir with Pibrentasvir, 17% and 12% reported pruritus and fatigue, respectively, according to Gain 2016, 2017a. Next we will discuss laboratory abnormalities. Laboratory abnormalities are not common unless the treatment regimen also includes ribavirin, in which case anemia and bilirubin elevations can be expected. According to the package insert, elevations in ALT, including those greater than 5 times the upper limit of normal, were identified in some patients treated with Elbasvir with Grazoprevir. These elevations occurred at treatment week 8 or later, patients were asymptomatic, and elevations resolved with ongoing therapy or at treatment completion. Similarly, a risk of ALT elevations occurred with Ombetasvir plus Paritaprevir plus Ritonavir plus Dasabuvir, as reported in the package insert. Elevations were asymptomatic and resolved with ongoing treatment. We will now discuss drug-drug interactions, abbreviated as DDIs. Clinically significant drug-drug interactions DDIs vary by DAA agent. An important resource for checking drug interactions is the University of Liverpool website. This free tool is updated often to provide timely drug interaction guidance. Specifics regarding the metabolism and pathways for potential drug interactions for individual drug-drug interactions are in Table 2 to 6. Several well-recognized clinically significant drug-drug interactions occur with the DAAs. P-glycoprotein, abbreviated as PGP, inducers and moderate to potent CYP inducers can reduce DAA concentrations. Rifampin, St. John's wort, phenytoin, and carbamazepine are all either contraindicated or not recommended with all DAAs. Serious symptomatic bradycardia was reported with the combined use of Ledipasvir plus Sofosbuvir and amiodarone. Thus, co-administration of any Sofosbuvir-based regimen with amiodarone is not recommended, according to Brainard 2015. Concomitant use of ethinyl estradiol-containing medications was associated with ALT elevations with both Ombetasvir plus Paritaprevir plus Ritonavir with or without Dasabuvir and Glecoprevir plus Pibrentasvir, prompting recommendations on both products' package inserts to avoid ethinyl estradiol-containing products while receiving either HCV therapy. Ledipasvir and Velpatasvir require an acidic environment for absorption. Acid-suppressive therapy can reduce treatment efficacy and thus require careful consideration regarding dose and timing of acid-suppressive agents. Small drug interaction studies show that omeprazole 20 mg may be used as long as it is administered at the same time as, or 12 hours before Ledipasvir plus Sofosbuvir. Response with other proton pump inhibitors (PPIs) is unknown. Conflicting real-world data were published regarding the impact of PPI use on SVR. In one study, once-daily PPI use did not appear to affect the SVR, though twice-daily dosing was associated with a lower SVR, according to Tapper 2016. However, a retrospective analysis in the Veterans Affairs reported that once-daily PPI use did affect the SVR, according to Bacchus 2016. Given the discordant data, the potential for treatment failure, and the ongoing challenges to treatment access, acid-suppressive therapy should be avoided in patients treated with the combination of ledipasvir plus sofosbuvir, sofosbuvir plus velpatasvir, and sofosbuvir plus velpatasvir plus vaxilloprevir. If acid-suppressive therapy cannot be discontinued, it should be minimized and careful attention is needed for the optimal timing of acid-suppressive medications. Histamine 2 receptor antagonists should be taken either at the same time or spaced 12 hours apart, and in contrast, antacids should be taken 4 hours after and stopped at least 8 hours before the next dose of ledipasvir plus sofosbuvir, sofosbuvir plus velpatasvir, and sofosbuvir plus velpatasvir plus vaxilloprevir. Statin use is relatively common among patients with liver disease. The drug interaction potential of individual statins varies by the agent and the HCV therapy. The clinical approaches to management can vary from reducing the statin dose while on HCV therapy to holding the statin while on HCV therapy. In addition to statin-induced myopathy caused by elevated statin concentrations with concurrent HCV treatment, concerns for concomitant use include elevated liver function tests, which can confuse the HCV treatment response. Pause the video and carefully scrutinize Table 2-6 summarizing HCV therapy metabolism and drug-drug interaction potential. Pause the video and carefully scrutinize Table 2-7 summarizing the available HCV DAA therapies. Next we will discuss DAA combination therapies. An overview of available HCV therapies is presented in Table 2-7. We will begin with ledipasvir plus sofosbuvir efficacy among treatment-naive patients. The ION-1 study established that a 12-week treatment of ledipasvir plus sofosbuvir was highly effective with more than a 95% SVR, and that patients could be treated without adding ribavirin. AFDAL 2014b. The ION-3 study, which included treatment-naive patients without cirrhosis with HCV genotype 1, showed that specific patient groups could successfully be treated with a shortened 8-week therapy, according to Nodley 2014. Specifically, a pretreatment HCV RNA of less than 6 million international units per milliliter correlated with a high SVR in patients treated for 8 weeks with ledipasvir plus sofosbuvir. Subsequent studies support this treatment option for treatment-naive patients without cirrhosis. However, this approach is not recommended for African American patients, given data showing a lower SVR for that patient population, according to the AASLD 2017 and SU 2017. Guidelines currently do not recommend the 8-week course in HIV/HCV co-infection. However, data increasingly support the abbreviated treatment duration for this patient population, according to Inglis 2016. We will now discuss treatment-experienced patients. Treatment-experienced patients, that is patients previously treated with pegylated interferon plus ribavirin with or without an NS3/4 API, achieved a high SVR with ledipasvir plus sofosbuvir treatment. A 12-week treatment of ledipasvir plus sofosbuvir with or without ribavirin resulted in a 94% SVR versus a 99% SVR among patients treated for 24 weeks, according to AFDAL 2014a. Adding ribavirin improved the SVR to 96% in the 12-week arm but did not change the SVR in the 24-week group. These results showed that for treatment-experienced patients, including patients with previous NS3/4 API therapy failure, adding ribavirin or extending the treatment duration improved SVR results. For TE patients with cirrhosis, the SVR rates were less than 90% with the 12-week treatment, indicating that extended therapy is needed to improve the SVR. Subsequently, the Sirius study found that patients with cirrhosis whose PI-based therapy had previously failed achieved a 96% SVR with ledipasvir plus sofosbuvir and ribavirin for 12 weeks versus a 97% SVR in patients treated for 24 weeks with ledipasvir plus sofosbuvir, according to Bourlier 2015. These data show that adding ribavirin can shorten treatment duration in more difficult-to-treat patients and result in SVR rates comparable with 24-week treatment with considerable cost savings. Regarding limitations, sofosbuvir is renally eliminated, thus, the combination of ledipasvir plus sofosbuvir is limited to patients with an eGFR of 30 ml per minute per 1.73 meters squared or higher and cannot be used in patients with end-stage renal disease. Although sofosbuvir has pan-genotypic activity, ledipasvir has limited efficacy in genotypes 2 and 3 and is thus not indicated in these infections. Because ledipasvir requires an acidic environment for absorption, careful attention must be paid to minimize the drug interactions between acid-suppressive therapy and ledipasvir plus sofosbuvir. Increasingly, data analyses show that the presence of baseline NS5A-IASs may affect the SVR in patients treated with ledipasvir plus sofosbuvir. Initial clinical trial data showed that specific IASs were uncommon and could mainly be overcome with a 12-week therapy, according to Sarrazin 2016. Emerging data show that ledipasvir-specific NS5A-IASs can reduce the SVR in treatment-experienced patients with genotype 1A re-treated with ledipasvir plus sofosbuvir, suggesting that IAS testing is indicated for specific patient populations, according to Zuzem 2017. The AASLD guidelines suggest that IAS testing should be considered in treatment-experienced patients with genotype 1A, see Table 2-2. Regarding the role in therapy, ledipasvir plus sofosbuvir is approved for use in adult and pediatric patients 12 years and older or weighing at least 35 kilograms for the treatment of genotypes 1, 4, 5, or 6. Ledipasvir plus sofosbuvir is recommended for HCV genotypes 1, 4, 5, or 6 in treatment-naive or treatment-experienced patients with or without cirrhosis, including patients with decompensated cirrhosis, in CTP class B or C, and liver transplant recipients, according to the AASLD 2017. Next we will look at elbasvir plus grazoprevir. We will consider its efficacy in treatment-naive patients. The CHTN study showed an overall 95% SVR in patients with HCV genotypes 1, 4, or 6, according to Zuzem 2015. In patients with HCV genotype 1A, a markedly reduced SVR of 58% was observed in those with baseline NS5A-IASs at positions 28, 30, 31, or 93 compared with a 99% SVR in patients without these specific IASs. Baseline NS3/4A substitutions had a minimal impact on the SVR in genotype 1A. Neither NS5A nor NS3/4A substitutions affected the SVR in patients with HCV genotype 1B, according to AASLD 2017. Given the difference in SVR rates when specific NS5A IASs are present, patients with genotype 1A require pretreatment NS5A IAS testing. If detected, ribavirin must be added to the regimen and the treatment extended to 16 weeks. The CEDGE COSTAR study examined HCV treatment in patients who inject drugs and are receiving opiate agonist therapy, according to DOR 2016. Participants were treatment-naive with HCV genotypes 1, 4, or 6. The SVR rates were high and similar to those of patients not receiving opiate agonist therapy. Of importance, most patients had positive urine drug screens and still achieved SVR rates greater than 90%, challenging the idea that patients must abstain from drug use for a predefined time in order to achieve successful HCV therapeutic outcomes. We will now discuss treatment-experienced patients. Patients who previously failed pegylated interferon and ribavirin for HCV genotypes 1, 4, or 6 were retreated with elbasvir plus grazoprevir in the CHTE study. Efficacy was high with an SVR of 92%. For patients with genotype 1A, the presence of RASs can markedly reduce the SVR and necessitates RAS testing before treatment initiation. Treatment-experienced patients whose prior PI, such as boceprevir, tenofovir, or cimeprevir therapy failed had an overall 96% SVR when retreated with elbasvir plus grazoprevir and ribavirin for 12 weeks in the C-Salvage study. For patients with genotype 1b and patients with genotype 1a and no evidence of NS5A RASs, elbasvir plus grazoprevir is recommended, according to AASLD 2017. However, in treatment-experienced patients with genotype 1a with known NS5A RASs at positions 28, 30, 31, or 93, elbasvir plus grazoprevir and ribavirin for 16 weeks is relegated to an alternative regimen, according to AASLD 2017, and Booty 2016. Next we will discuss the limitations. Elbasvir plus grazoprevir is contraindicated for use in patients with CTP class B or C cirrhosis. Therefore, elbasvir plus grazoprevir is limited for use in patients without cirrhosis or in those with compensated cirrhosis consistent with CTP class A. For patients with HCV genotype 1A, the need for pre-treatment RAS testing can delay start of therapy and if resistance is identified, requires a change in therapy. Initial data and the package insert suggest that patients with baseline RASs can successfully be treated by adding ribavirin and extending the treatment to 16 weeks. However, the need for concomitant ribavirin can be a limitation because ribavirin poses its own adverse effects and laboratory abnormalities. Moreover, ribavirin accumulates in patients with renal insufficiency, thus posing a substantial challenge to dosing in patients on dialysis, with most clinicians avoiding the use of ribavirin in this population altogether. Next we will discuss role in therapy. Elbasvir plus grazoprevir is indicated for patients with HCV genotypes 1 and 4. It may be used in patients without cirrhosis or in patients with compensated cirrhosis consistent with CTP class A, according to AASLD 2017. The regimen can be used in patients who are treatment naive or treatment experienced with pegylated interferon and ribavirin with or without a PI. Of importance, elbasvir plus grazoprevir can be used in patients with renal insufficiency, including end-stage renal disease and hemodialysis. Therapy duration and need for ribavirin vary, however, if ribavirin is required, the therapeutic combination becomes an alternative by AASLD guidelines in recognition of the added adverse effect profile and toxicity associated with ribavirin use. Next we will discuss sofosbuvir plus velpatasvir. We will begin with its efficacy. Efficacy of sofosbuvir, velpatasvir for genotypes 1, 2, 4, 5, or 6 was shown in the Astral-1 study of 624 treatment-naive and treatment-experienced patients with an overall SVR of 99%, according to Feld 2015. Patients with cirrhosis also did well, with a 99% SVR. The Astral-2 and Astral-3 trials, published concurrently, showed the superiority of sofosbuvir plus velpatasvir for HCV genotypes 2 and 3, respectively, to the prior standards of care of sofosbuvir and ribavirin for these infections, according to Foster 2015. The SVR improved in treatment-naive and treatment-experienced patients and in patients with and without cirrhosis. Baseline NS5A/RASs did not affect the SVR in patients with genotype 1, however, there are concerns for reduced SVR in patients with genotype 3 and in particular among genotype 3 patients who are either treatment-experienced or have cirrhosis and have NS5A/RAS. Patients with no baseline NS5A/RASs had a 97% SVR compared with an 88% SVR in those with baseline RASs. Although only 25 patients had the Y93 mutation, the SVR was further reduced to 84%. Because of these findings, the national guidelines recommend NS5A/RAS testing for patients with genotype 3 who have compensated cirrhosis or prior treatment experience. If the Y93 mutation is found in treatment-naive patients with cirrhosis, ribavirin should be added, or sofosbuvir plus velpatasvir plus varxilo-previr should be used, according to AASLD 2017. Similarly, ribavirin should be added if sofosbuvir plus velpatasvir is used in treatment-experienced patients without cirrhosis who are found to have the Y93 mutation. See Table 2-2. For other treatment-experienced patients with compensated cirrhosis, sofosbuvir plus velpatasvir with ribavirin is an alternative regimen because of the need for concomitant ribavirin, according to AASLD 2017. Next we will discuss limitations. Sofosbuvir is renally eliminated, thus, its use is limited to patients with an eGFR of 30 ml per minute per 1.73 meters squared or higher, and it cannot be used in patients with end-stage renal disease. Patients who must be maintained on acid-suppressive therapy must be carefully treated to minimize the drug interactions between acid-suppressive therapy and velpatasvir. Similar to ledipasvir, velpatasvir also requires an acidic environment for absorption. Unlike ledipasvir, concomitant use of PPIs should be avoided with velpatasvir. If medically necessary, a maximum dose of omeprazole 20 mg daily can be administered 4 hours after a dose of velpatasvir is administered with food. However, even in this setting, the Cmax and AUC of velpatasvir are reduced, raising concerns for HCV treatment failure. Next we will discuss their role in therapy. Sofosbuvir plus velpatasvir is indicated and recommended by national guidelines for treatment-naive or treatment-experienced patients with HCV genotypes 1-6, irrespective of liver disease status, according to AASLD 2017, Feld 2015, and Foster 2015. Sofosbuvir plus velpatasvir is approved for use in patients without cirrhosis as well as in patients with compensated or decompensated cirrhosis. For patients with genotype 3 with prior peginterferon plus ribavirin experience, sofosbuvir plus velpatasvir for 12 weeks is recommended by the national guidelines, though pre-treatment resistance testing for the Y93 substitution is required. Next we will discuss paritaprevir plus ritonavir plus ombetasvir with or without dasabuvir. The regimen of paritaprevir plus ritonavir plus ombetasvir plus dasabuvir was approved in 2014 for genotype 1. This regimen was then reformulated as an extended-release formulation in 2016, allowing for once-daily dosing. Ritonavir is used as a pharmacologic booster for paritaprevir and has no efficacy against HCV. Dasabuvir has no efficacy in genotype 4, hence, the specific formulation of ombetasvir plus paritaprevir plus ribavirin for genotype 4. Next we will discuss its efficacy. The effectiveness of paritaprevir plus ritonavir plus ombitesvir plus dasabuvir in treatment-naive patients with genotypes 1A and 1B was shown in the Pearl 4 and Pearl 3 studies, respectively, according to Andreone 2014, and Ferenczi 2014. For patients with genotype 1A, ribavirin was necessary to achieve an SVR of 97%. For patients with genotype 1B, SVR was over 99% without ribavirin, according to Ferenczi 2014. Effectiveness of the combination without ribavirin in patients with genotype 1B was also shown with a 100% SVR in patients without cirrhosis who previously failed pegylated interferon, ribavirin, and tenofovir therapy, according to Andreone 2014. In a large trial of 631 treatment-naive patients, paritaprevir plus ritonavir plus ombitesvir plus dasabuvir with ribavirin achieved a 96.2% SVR in patients with genotype 1 and identified reduced trends in SVR among patients with increasing fibrosis stage or obesity, according to Feld 2014. In patients with cirrhosis and genotype 1A, a 24-week therapy is needed. A shorter, 12-week treatment resulted in a substantially reduced SVR compared with patients treated for 24 weeks, hence, the treatment duration should be extended for this patient population, according to Pordad 2014. Paritaprevir plus ritonavir plus ombitesvir with or without dasabuvir was also a safe and effective option in patients with advanced renal disease, according to Pocros 2016. Subsequently, the combination was approved for patients with renal impairment, including patients receiving hemodialysis. Paritaprevir plus ritonavir plus ombitesvir is also effective for genotype 4, Hezode 2015. In the Pearl 1 trial, 42 patients without cirrhosis with genotype 4 were treated for 12 weeks and achieved a 100% SVR. Next we will discuss treatment limitations. According to the paritaprevir plus ritonavir plus ombitesvir package insert, therapy is contraindicated in patients with decompensated cirrhosis, defined as CTP class B or C cirrhosis. Original approval for the treatment neither recommended nor contraindicated its use in patients with CTP class B cirrhosis. However, hepatic decompensation and hepatic failure, including the need for liver transplantation and death, were reported in post-marketing surveillance in at least 26 cases, which resulted in the labeling change, FDA 2015. Liver injury occurred within 1 to 4 weeks after starting treatment. Current recommendations include monitoring for worsening liver disease in patients with cirrhosis who are starting ombitesvir plus paritaprevir plus ritonavir with or without dasabuvir, according to AASLD 2017. Next we will discuss the role in therapy. Paritaprevir plus ritonavir plus ombitesvir with or without dasabuvir is an alternative therapy for patients with genotypes 1 or 4, according to AASLD 2017. However, use of the combination has declined with the availability of more potent therapies. Next we will discuss the combination of sofosbuvir plus velpatasvir plus vaxilloprevir. Approved in July 2017, the single combination tablet of 400 mg of sofosbuvir and 100 mg of velpatasvir includes 100 mg of vaxilloprevir, a new pan-genotypic NS3/4 API. The combination is indicated for patients with genotypes 1 to 6 without cirrhosis or with compensated cirrhosis whose prior regimen containing an NS5A inhibitor has failed. The combination is also indicated in patients with genotype 1A or 3 who were previously treated with sofosbuvir without an NS5A inhibitor. The combination is expected to be well tolerated. However, in addition to the previously ascribed adverse events with sofosbuvir plus velpatasvir, clinical trials showed that vaxiloprevir is associated with diarrhea. Regarding its efficacy, the triple combination was efficacious in patients with genotypes 1 to 6 with prior NS5A inhibitor experience in the Polaris-1 trial, according to Bourlier 2017. Most patients had genotype 1A and achieved a 96% SVR, 97 of 101, after a 12-week therapy. Including all genotypes, the presence of cirrhosis reduced SVR to 93%, 113 of 121, compared with the 99% SVR in patients without cirrhosis. All virologic failures occurred in patients with cirrhosis, including 6 patients with relapse and 1 on-treatment failure. The presence of baseline RASs did not appear to affect SVR because SVR rates were high regardless of whether RASs were present. The combination of sofosbuvir plus velpatasvir plus vaxiloprevir was compared with sofosbuvir plus velpatasvir in treatment-experienced patients with genotypes 1 to 6 whose sofosbuvir therapy without an NS5A inhibitor had failed. For most patients, N equals 69, prior sofosbuvir and ribavirin therapy had failed. Other prior regimens included sofosbuvir with cimaprevir or other combinations, including sofosbuvir with an HCV-PI. The 97% SVR, that is 177 of 182, achieved in the sofosbuvir plus velpatasvir plus vaxiloprevir arm was statistically superior with a p-value less than 0.001 to the 90% SVR, that is 136 of 151, achieved in the sofosbuvir plus velpatasvir arm. Adding the PI did not improve the SVR in patients with genotypes 1b, 2, 4, 5, or 6. In contrast, patients with genotype 1A had a 98% SVR if treated with the addition of vaxiloprevir, compared with 89% if treated with sofosbuvir plus velpatasvir. For genotype 3, SVR rates were 94% with sofosbuvir plus velpatasvir plus vaxiloprevir compared with 85% with sofosbuvir plus velpatasvir. Regarding the limitations of this combination, although both sofosbuvir and velpatasvir can be used in patients with decompensated cirrhosis, adding vaxiloprevir limits the use of the triplet to patients with compensated cirrhosis because of concerns for the PI contributing to worsening liver failure in this difficult-to-treat patient population. Similarly, because of the sofosbuvir component, patients with renal insufficiency are not candidates for the treatment. Next we will discuss the role in therapy. Sofosbuvir plus velpatasvir plus vaxiloprevir is indicated in patients with genotype 1 infections and prior treatment failure with DAAs. Given the challenges of treating patients with genotype 3, the combination therapy is also indicated in treatment-naive patients with compensated cirrhosis who have the Y93 mutation and for treatment-experienced patients, including patients with prior pegylated interferon plus ribavirin or DAA experience. Next we will discuss the combination of glecaprevir plus pibrentasvir. Glecaprevir plus pibrentasvir was approved in August 2017 for HCV genotypes 1 to 6 in patients without cirrhosis or with compensated cirrhosis. Both glecaprevir and pibrentasvir have pan-genotypic activity against the major HCV genotypes and more potent activity, including against some of the more common NS3/4A and NS5A RASs, according to Pordad 2017. Regarding its efficacy, in the dose-finding trials Surveyor 1 and Surveyor 2, treatment-naive and treatment-experienced patients without cirrhosis with genotypes 1 to 6 were treated with glecaprevir plus pibrentosphere with or without ribavirin for 8 or 12 weeks, according to Quo 2017. Results showed high SVRs, 97% to 100% for genotype 1, 96% to 100% for genotype 2, 83% to 94% for genotype 3, and 100% for genotypes 4 to 6. The highest efficacy occurred with the doses in the approved combination tablet. Treatment-naive patients without cirrhosis with genotypes 1 to 3 achieved a high SVR with the 8-week treatment, suggesting this as an option for that patient population. However, a longer therapy duration or the addition of ribavirin may be needed, particularly for treatment-experienced patients with genotype 3. Of the 449 treated patients, 10 had virologic failure, and 9 were among the patients with genotype 3. Patients with cirrhosis and genotype 3 were evaluated in a separate analysis using glecaprevir plus pibrentosphere with or without ribavirin for 12 weeks, according to Gain 2016. Among the 28 patients treated without ribavirin, 1 treatment-experienced patient's retreatment failed. In contrast, all 27 patients with cirrhosis and genotype 3 treated with glecaprevir plus pibrentosphere and ribavirin achieved SVR. Baseline RASs did not affect the SVR because all 11 patients with NS5A mutations achieved SVR. Similarly, in 14 patients with cirrhosis and genotype 1, all but 1 achieved SVR. In the Magellan-1 trial, glecaprevir plus pibrentosphere with or without ribavirin was evaluated in patients without cirrhosis with GT1 with prior DAR treatment experience, according to Pordad 2017. Most patients had baseline RASs, either NS3 or NS5A, and 15 patients had both NS3 and NS5A RASs. Of the 17 patients who were previously treated with either an NS5A inhibitor or an NS3/4 API, 16 achieved SVR corresponding to 94% with a 16-week course of therapy and 1 had on-treatment virologic failure. Adding ribavirin did not appear to affect the SVR. Adverse events with glecaprevir plus pibrentosphere were similar to those previously reported with other DAAs, namely, fatigue, headache, and nausea. Laboratory abnormalities were rare and included an AST elevation not attributable to the HCV therapy and an isolated elevation of bilirubin in a patient not taking ribavirin. Regarding the limitations of this combination, because of the PI glecaprevir plus pibrentosphere therapy is not recommended for patients with CTP class B and is contraindicated in CTP class C. Regarding the role in therapy, glecaprevir plus pibrentosphere offers a pan-genotypic, 8-week treatment for treatment-naive patients without cirrhosis and a 12-week treatment for patients with compensated cirrhosis. Glecaprevir plus pibrentosphere allows treatment in patients with genotypes 1 to 6 and end-stage renal disease. Glecaprevir plus pibrentosphere is recommended for use in patients with prior NS3/4 API therapy failure and prior non-NS5A, sofosbuvir-treated patients. However, although glecaprevir plus pibrentosphere is FDA indicated for patients with prior NS5A therapy failure, by the national guidelines, the combination is identified as an alternative regimen for this patient population, according to the AASLD 2017. The WAC of glecaprevir plus pibrentosphere garnered substantial interest and appeal, predicting that the combination will play a major role in HCV therapy. Next we will discuss single agents. Combination DAA therapy is the standard of care, thus, use of single agents is limited. Newer DAAs are available as combination therapies, thus replacing the need for several single agents. Moreover, because single agents are produced by different pharmaceutical manufacturers, the cost of single agents is often higher than the cost of existing combination therapies. We will first of all discuss Simon-Previa, approved for use in 2013. Simon-Previa is an NS3/4A inhibitor that is categorized as a second-generation PI, according to the package insert. Approval and use of Simon-Previa in combination with sofosbuvir, with or without ribavirin, marked the first all-oral treatment option for HCV genotype 1. Regarding its efficacy, the key studies showing the ability to treat HCV genotype 1 infections with an all-oral regimen was the COSMOS trial of Simon-Previa and sofosbuvir with or without ribavirin in both treatment-naive and treatment-experienced patients, according to Lavitz 2014. The SVR rates were 90% and above. Subsequent studies include Optimist 1 and Optimist 2, which recognized the impact of the baseline Q80K mutation on SVR in patients with genotype 1A, according to Quo 2016, Lavitz 2016. In Optimist 1, the Q80K mutation reduced the SVR in the 8-week treatment to 73%, though the SVR was over 95% in patients treated for 12 weeks, according to Quo 2016. In Optimist 2, which included patients with compensated cirrhosis, the overall SVR was 83%, according to Lavitz 2016. Patients with HCV genotype 1A and the Q80K mutation had a substantially lower SVR at 74% than did patients without the mutation, at 92%. Regarding the limitations of this combination, Simon-Previa's use is limited primarily because of the substantial cost of using individual agents from different manufacturers and the availability of single-tablet combination regimens. Simon-Previa, like all NS3/4A inhibitors, is not recommended for use in patients with decompensated cirrhosis because of concerns for worsening liver disease, including hepatic failure. In genotype 1A, the efficacy of Simon-Previa is substantially reduced by the Q80K mutation, thus, NS3/4A RAS testing must be done before using Simon-Previa in genotype 1A. If the Q80K mutation is detected, an alternative HCV treatment regimen should be used. Most clinicians will likely opt to use other regimens for genotype 1 in lieu of testing for the Q80K mutation. Regarding its role in therapy, Simon-Previa is highly effective in genotype 1 but is an alternative therapy in combination with sofosbuvir for genotype 1A and 1B without cirrhosis. Because of the availability of combination tablets, Simon-Previa's use is limited. Next we will discuss daclatosvir. Daclatosvir is an NS5A inhibitor used in combination with sofosbuvir, with or without ribavirin, for the treatment of genotype 1 or 3. In patients with genotype 1A and cirrhosis, NS5A RAS testing is recommended because of concerns for reduced SVR if the patient has NS5A RAS. The standard dose is 60 mg dosed once daily with or without food. Daclatosvir is the only DAA available in different dosage strengths to allow for dose adjustment if used with strong CYP3A inhibitors 30 mg tablet or moderate CYP3A inducers or nevirapine 90 mg tablet. Regarding their efficacy, daclatosvir and sofosbuvir with or without ribavirin is highly effective for treatment-naive and treatment-experienced patients with HCV genotype 1, 2, or 3, according to Sulkowski 2014. The SVR rates were 98% for genotype 1, irrespective of prior treatment experience or subtype, i.e., 1A versus 1B. Lower SVR rates were noted for genotype 3 at 89%. A subsequent study of daclatosphere and sofosbuvir with ribavirin showed the challenge of successfully treating patients with advanced cirrhosis with an overall SVR at 83% and a marked decline in SVR rates with progressive CTP class, 92% SVR with CTP class A, 94% with CTP class B, and 56% with CTP class C, according to Pordad 2016. Next we will discuss the limitations of daclatosphere. A main limitation of daclatosphere is that it is not co-formulated with another DAA, thus, the acquisition of individual therapies is often cost-prohibitive. Due to the availability of combination tablets, daclatosphere's use is limited. In patients with genotype 3, cirrhosis resulted in reduced SVR rates, according to Pordad 2016. Regarding its role in therapy, given the availability of co-formulated therapies, the use of daclatosphere with sofosbuvir is now recognized as an alternative regimen in the guidelines for all genotypes, according to AASLD 2017. Next we will discuss sofosbuvir. Sofosbuvir was approved in 2013 as a single agent for use in conjunction with interferon or another DAA. Sofosbuvir has pan-genotypic activity and is thus used for genotypes 1 to 6, including in patients without cirrhosis or with cirrhosis, including CTP class A, B, or C. For study data details of sofosbuvir in combination with other therapies, see the respective combination treatment. Regarding its limitations, sofosbuvir must be used in combination with other therapies or resistance can develop with loss of virologic response. Because sofosbuvir is renally eliminated, all sofosbuvir-based therapies are limited to use in patients with an eGFR of 30 ml per minute per 1.73 meters squared or higher. Regarding its role in therapy, currently, sofosbuvir is primarily used as a backbone of treatment for single-tablet combination therapy as ledipasvir plus sofosbuvir R, sofosbuvir plus velpatasvir, or sofosbuvir plus velpatasvir plus vaxilaprevir. Although largely supplanted by combination therapies, as a single agent, sofosbuvir can be combined with cimaprevir or daclatosphere, with or without ribavirin. Next we will discuss ribavirin. Available in various dosage strengths and from different manufacturers, ribavirin has been a mainstay of HCV therapy since 1998. Ribavirin is a purine nucleoside analog whose mechanism of action in HCV is not completely understood. Ribavirin is ineffective as monotherapy and was historically used in combination with interferon for HCV treatment, according to Manns 2001. Ribavirin is generally dosed by body weight, with 1,000 mg recommended for patients weighing less than 75 kg and 1,200 mg for patients weighing more than 75 kg. Ribavirin dosing may be adjusted on the basis of hemoglobin concentrations, renal function, and risk of anemia developing on treatment. Patients with decompensated cirrhosis are often started at a lower dose initially and titrated up based on clinician preference and patient tolerability. Regarding its efficacy, the efficacy of ribavirin in treating HCV was initially shown with an improved SVR compared with interferon and subsequently with pegylated interferon monotherapy, according to Fried 2002, and McHutchison 1998. Increasing the ribavirin dosing to adjust for patient weight in genotype 1 resulted in a higher SVR for interferon-based therapies and underscored the need to maximize ribavirin exposure, according to Jacobson 2007. With the availability of increasingly more potent DAAs, the need for ribavirin continues to decline. However, ribavirin is still recommended, especially among patients identified as more difficult to treat such as those with decompensated cirrhosis, for whom it can improve SVR rates. Regarding its limitations, ribavirin causes several adverse effects and laboratory abnormalities and can be particularly challenging to use in patients with advanced cirrhosis. Ribavirin causes hemolytic anemia, and patients must be monitored for changes in hemoglobin and/or hematocrit. Moreover, because of its renal elimination, ribavirin requires dose adjustment in patients with impaired renal elimination or receipt of hemodialysis because changes in renal function will exacerbate anemia. Hemolysis can also contribute to elevated bilirubin. Ribavirin can have teratogenic effects, thus, it should be avoided in pregnancy and among pregnant partners of male patients taking ribavirin. Women of childbearing capacity should be tested for pregnancy before use and should use 2 forms of contraception while taking ribavirin. Because of ribavirin's long half-life, pregnancy should be avoided for at least 6 months after completing ribavirin. Ribavirin is also associated with fatigue, rash, nausea, and itching. Regarding its role in therapy, in particular, patients identified as difficult to treat, including patients with advanced cirrhosis, treatment experience, prior DAA therapy failures, or known resistance substitutions, often receive concomitant ribavirin to maximize SVR, according to AASLD 2017. With the availability of more potent therapies, ribavirin use continues to decline. Ribavirin continues to be recommended in certain subsets of patients and is most notably used in addition to sofosbuvir plus velpatasvir plus vaxilloprevir, for re-treating patients with genotype 3 and cirrhosis in whom a previous DAA regimen has failed, according to AASLD 2017. Pause the video and carefully scrutinize Table 2-8 summarizing the recommended and alternative regimens for HCV genotype 1 in treatment-naive patients. Pause the video and carefully scrutinize Table 2-9 summarizing the recommended and alternative regimens for HCV genotype 2 or 3 infection in treatment-naive patients. Pause the video and carefully scrutinize Table 2-10 summarizing the recommended regimens for treatment-experienced patients. Pause the video and carefully scrutinize Table 2-11 summarizing the recommended treatments for patients with decompensated cirrhosis. And now we will discuss recommended regimens for chronic HCV infection. Table 2-8 and Table 2-9 list regimens for HCV genotype 1 and genotype 2 or 3 in treatment-naive patients. First we will look at the difference in management if compensated cirrhosis is present. In clinical trials, data indicated no difference in SVR rates between treatment-naive patients without cirrhosis and those with CTP class A cirrhosis, according to Feld 2015, Zuzem 2015, Afdal 2014, and Pordad 2014. Nonetheless, a shorter 8-week therapy is only recommended in patients without cirrhosis and only with select regimens. Once patients have cirrhosis, the recommended therapy duration is 12 weeks. The national guidelines recommend therapeutic regimens without ribavirin. If concomitant ribavirin is needed for a selected regimen, that therapy becomes an alternative treatment option, shown in Table 2-8, according to the AASLD 2017. The presence of compensated cirrhosis affects the treatment of patients with HCV genotype 3. Patients with compensated cirrhosis require RAS testing to determine the need for concomitant ribavirin if using sofosbuvir plus velpatasvir or daclatasvir plus sofosbuvir, according to the AASLD 2017. If RAS testing is positive for the Y93 substitution, ribavirin must be added or the treatment changed to sofosbuvir plus velpatasvir plus vaxilloprevir, as shown in Table 2-9. In comparison, treatment-naive patients without cirrhosis do not require RAS testing, and there are no recommendations to test for RAS when using glecoprevir plus pibrentasvir. Next we will discuss the difference in management if decompensated cirrhosis is present. Patients who have decompensated cirrhosis, consistent with moderate to severe hepatic dysfunction and defined as CTP class B or C cirrhosis, can pose clinical challenges to treatment, according to the AASLD 2017. Few studies of HCV therapies included patients with decompensated liver disease, and of the studies available, most patients are CTP class B. This patient population is at high risk of morbidity and mortality because of the underlying liver disease. National HCV treatment guidelines recommend that patients with CTP class B and C cirrhosis be treated by clinicians with expertise in managing cirrhosis because of the risks of worsening liver disease, including death and need for liver transplantation, according to the AASLD 2017. The presence of decompensated liver disease limits HCV therapeutic options. The combination of paritaprevir plus ritonavir plus ombitosvir with or without dasabuvir is contraindicated in patients with CTP class B and C cirrhosis because of concerns for hepatic decompensation and hepatic failure. The PAIs as a class are not recommended in patients with decompensated liver disease. Thus, the combination of elbasvir plus grazoprevir is contraindicated in CTP class B and C cirrhosis because of concerns for accumulation of grazoprevir and the risk of increased ALT concentrations in this patient population. Similarly, cimaprevir, glecaprevir, and vaxiloprevir are not recommended for use in CTP class B or C cirrhosis. The only therapies recommended for use in decompensated cirrhosis in patients with genotype 1, 4, 5, or 6 are ledipasvir plus sofosbuvir, sofosbuvir plus velpatasvir, and daclatasvir with sofosbuvir, according to the AASLD 2017. All include the concomitant use of ribavirin for a planned duration of 12 weeks, or if patients are ineligible for ribavirin, treatment is extended to 24 weeks as shown in Table 2-11. Ribavirin can be challenging to use in patients with this level of liver disease because of its adverse reaction of hemolytic anemia, and many patients with decompensated cirrhosis are already anemic at baseline. Thus, patients may be treated without ribavirin, but this strategy requires extending the treatment to 24 weeks. In patients with prior sofosbuvir or NS5A based treatment failure and decompensated cirrhosis, retreatment includes ribavirin and is extended to 24 weeks, according to the AASLD 2017. Next we will discuss special populations. Let's consider HCV treatment in patients with decompensated cirrhosis or after liver transplantation. Few studies focus on patients with decompensated liver disease or in the post-transplant setting, often studied together. See Table 2-12. The SOLAR-1 trial included two cohorts. Cohort A included pre-transplant patients who had CTP class B or C cirrhosis, and Cohort B included patients post-transplantation, according to Charlton 2015. All patients received either a 12 or a 24-week course of ledipasvir plus sofosbuvir and ribavirin. Results from Cohort A indicated comparable SVR rates at 87% or 88% regardless of whether patients were treated for 12 or 24 weeks, with a similar but numerically lower SVR for CTP-C than for CTP-B. The post-transplant group also achieved a high SVR, but rates were lower with progressively worse liver disease as defined by a higher CTP score, suggesting that a 12-week treatment is inadequate in individuals with CTP class C cirrhosis. Patients achieving SVR had markedly improved liver function, as measured by laboratory tests and evidenced by reductions in their model for end-stage liver disease, abbreviated as MELD, and CTP scores. The Astral-4 trial showed the safety and efficacy of sofosbuvir plus velpatasvir in treating patients with genotype 1, 2, 3, 4, or 6 and decompensated cirrhosis, specifically CTP class B, according to Curry 2015. The overall SVR was higher at 94% with the addition of ribavirin and a 12-week treatment. Adding ribavirin resulted in a higher SVR than did extending the treatment to 24 weeks. For patients with genotype 3, the 85% SVR was lower than for patients with other genotypes, despite adding ribavirin. The MELD scores were improved for most patients, especially those with a baseline MELD score greater than 15, a score above which many patients are listed for liver transplantation. Recommendations for treating patients with HCV and decompensated liver disease include concomitant ribavirin for 12 weeks. If patients are ineligible for ribavirin, the recommended treatment duration is extended to 24 weeks, according to the AASLD 2017. Pause the video and carefully scrutinize Table 2 to 12 summarizing the recommended regimens in patients with decompensated cirrhosis and prior sofosbuvir or NS5A-based treatment failure. And now we will discuss HIV-HCV co-infection. Patients with HCV who are co-infected with HIV are essentially treated the same as those with HCV monoinfection and can expect similar rates of SVR and adverse events, according to Nagy 2015, Rockstro 2015, Wiles 2017, and Wiles 2015. The main difference in the treatment approach is that data are limited supporting an 8-week treatment of ledipasvir plus sofosbuvir in HIV co-infection, thus, it is not recommended, according to the AASLD 2017. Although ledipasvir plus sofosbuvir, sofosbuvir plus velpatasvir, elbasvir plus grazoprevir, and glecoprevir plus pibrentasvir currently have indications to treat HCV/HIV co-infected patients, there is no indication that other HCV DAAs are ineffective in this patient population. The main challenge of treating HIV-HCV co-infection is in the drug-drug interaction management and potential antiretroviral drug therapy switches, thus, co-management with an HIV practitioner is recommended, according to the AASLD 2017. Marovirok, dolutegravir, raltegravir, and tenofovir alafenamide are least likely to have a drug-drug interaction with the DAAs. If antiretroviral drug therapy cannot be modified, the recommended HCV-DAA therapy is daclatasvir plus sofosbuvir with or without ribavirin, according to the AASLD 2017. Next we will discuss HCV treatment in patients with renal insufficiency. Historically, patients with renal insufficiency were challenging to treat because of concerns for drug accumulation. Approval of elbasvir plus grazoprevir included the first FDA-approved use for patients with renal insufficiency, including hemodialysis and extended treatment availability to this patient population. Safety and efficacy were shown in the C-SURFER trial of patients with genotype 1 and were comparable with that of patients without renal insufficiency, according to Roth 2015. Subsequently, in 2017, approval of glecoprevir plus pibrentasvir expanded HCV treatment to patients with genotype 1 to 6 and renal insufficiency, including hemodialysis. The Expedition 4 trial included patients with genotypes 1 to 6 and stage 4 and 5 chronic kidney disease. The overall SVR was 98% with safety and efficacy comparable with that in patients without renal insufficiency, according to the AASLD 2017, and GAIN 2017a. An ongoing challenge in treating patients with renal insufficiency includes treating patients with underlying decompensated cirrhosis, CTP class B or C. Despite their use in decompensated cirrhosis, the combination therapies ledaspivir, sofosbuvir and sofosbuvir plus velpatasvir and other sofosbuvir-based combinations are not recommended because of concerns for accumulation of sofosbuvir and its main metabolite GS331007. Next we will discuss retreatment after DAA therapy failure. Despite the high SVR rates with DAA therapy, treatment failure does occur, as shown in Table 2-13. Sofosbuvir plus velpatasvir plus varxaloprevir for 12 weeks was specifically approved for use in patients with prior DAA treatment failure. This combination is recommended for use in patients with genotype 1 with DAA experience, including prior NS5A and/or sofosbuvir treatment failure, and in patients with genotype 3 whose prior DAA regimen failed, including an NS5A inhibitor. In DAA-experienced patients with genotype 3, the presence of underlying cirrhosis and of the Y93RAS affect SVR rates, thus, adding ribavirin is also recommended, according to the AASLD 2017, and GAIN 2017b. Retreatment is indicated for 12 weeks. In patients with genotype 1 whose non-NS5A regimen with sofosbuvir previously failed, glecaprevir plus pibrentasvir for 12 weeks is recommended. Despite receiving indications for retreatment in DAA failures, including prior NS5A inhibitor or NS3/4A PI therapy but not both, the national guidelines have limited recommendations for glecaprevir plus pibrentasvir in DAA failures because of the small number of patients in clinical trials, according to the AASLD 2017. Glecaprevir plus pibrentasvir is not recommended in patients with genotype 3 and with prior DAA therapy failure. The combination is recommended in prior sofosbuvir plus ribavirin therapy failures for patients with genotype 2. Although both sofosbuvir plus velpatasvir plus varxaloprevir and glecaprevir plus pibrentasvir offer the opportunity to retreat prior DAA-experienced patients, they are not approved for use in patients with decompensated cirrhosis. Retreating prior DAA failure in the setting of decompensated cirrhosis remains a therapeutic challenge. Pause the video and carefully scrutinize Table 2-13 summarizing retreatment after DAA therapy failure. Pause the video and carefully scrutinize Table 2-14 illustrating opportunities for pharmacists in HCV care. Here now are a few practice points. The presence of the HCV antibody alone does not indicate chronic infection, nor does it confer immunity against HCV infection. Confirmation of HCV infection requires a quantifiable HCV RNA. Patients with HCV require an assessment of their underlying liver function to identify appropriate HCV therapeutic options. The presence of cirrhosis affects HCV therapy choices and need for post-HCV therapy management, including ongoing hepatocellular carcinoma surveillance. Patients without cirrhosis or with compensated cirrhosis defined as CTP Class A cirrhosis can be treated with any of the currently available therapies. Patients with decompensated cirrhosis, defined as CTP Class B or C cirrhosis, can be treated with ledaspivir plus sofosbuvir, sofosbuvir plus velpatasvir, or sofosbuvir and daclatasvir. PI-based therapies should not be used in patients with decompensated cirrhosis. Sofosbuvir-based therapies cannot be used in patients with renal insufficiency. Patients with renal insufficiency, including those undergoing hemodialysis, may be treated with elbasvir plus grazoprevir, glecaprevir plus pibrentasvir, or paritaprevir boosted with ritonavir plus ombetasvir with or without das-abuvir. Patients whose non-NS5A, sofosbuvir-based regimen or NS5 A inhibitor therapy has failed can be retreated with sofosbuvir plus velpatasvir plus vaxilloprevir. Patients whose NS5 A agent or NS3/4 A inhibitor therapy, but not both, has failed can be retreated with glecoprevir plus pibrentasvir. And now in conclusion, pharmacist-delivered HCV care can vary with the scope of practice and encompass a large spectrum of HCV-related care, as shown in Table 2 to 14. Screening for HCV remains a priority, with opportunities in both the outpatient ambulatory care setting and a hospital or acute care setting. Patient support services, ranging from financial assistance to on-treatment specialty care, pharmacy monitoring and counseling, are instrumental in achieving good outcomes. Pharmacists also manage HCV clinics for follow-up care and, in some areas, may be the prescribing clinicians for HCV care. Many public and private insurances restrict HCV therapy to specialists, despite data indicating that non-specialists can safely and effectively treat HCV, according to Aurora 2011, and Belperio 2017. Additional research documenting HCV outcomes by pharmacists is needed. Direct-acting antivirals are highly effective in achieving SVR for patients with chronic HCV. Current therapies achieve SVR in more than 90% of patients and are well tolerated, with minimal adverse effects and laboratory abnormalities. The presence of cirrhosis, particularly decompensated cirrhosis, can reduce the SVR, which limits the available therapies to non-PI-based regimens. Despite improved treatment, ribavirin remains a mainstay of therapeutic regimens in select patient populations. For patients who can tolerate ribavirin, adding ribavirin can improve SVR, decrease treatment duration, and overcome NS5 resistance substitutions. Newer, more potent antivirals offer the potential to treat some patient populations for shorter courses of therapy and an option for retreating prior DAA therapy failures. These new agents hold substantial promise in achieving SVR in more challenging patient populations, not only in patients whose prior DAA therapy has failed but also in patients with genotype 3. Elimination of HCV as a public health threat is a goal recognized by the U.S. Department of Health and Human Services, according to DHHS 2017. Ultimately, the challenge in HCV therapy is access to HCV medications for all patients with chronic HCV, a challenge and opportunity for pharmacists to embrace. Thank you.